doesn't happen if you have a non-LBBB morphology. For some of the practicing physicians, especially for some of the postgraduates, this is an important slide. This was way back described in ECG text. If you take two patients with a right bundle branch morphology, patients with a 2 RBBB in lead, it affects your total mortality and the survival is less in that. So it's important as a physician to ensure that there is 100% of a left ventricular capture. This is data from Cleveland Clinic. Millens looked at over about 30,000 patients to look at what are the common reasons why the CRT fails to deliver. And the commonest reason is patients with heart failure, you and me know, very often have PVCs, PACs, frequent runs of atrial flutter fibrillation, which limits the delivery of the cardiac resynchronization therapy. You have done a great job. You have put an expensive device, but it's not delivering its work. And therefore, the patients, this happens fairly frequently among patients with heart failure. So if you look at patients among non-responders of CRT, apart from suboptimal AV delay that is programmed, frequent reason for non-responder is an arrhythmia and suboptimal LV lead position. We'll address this one by one. Now you know that some of these patients with cardiomyopathy or an old infarct are likely to have fibrosis, especially mid-wall fibrosis in the left ventricle. This is emerging as an important risk factor for non-response among CRT. The present issue of JACC has this mid-wall fibrosis in left ventricle. If you have a significant scar in the place where you implant a left ventricular lead, you find that mortality goes up compared to implanting a lead in a non-scarred area. So you may be getting into a lateral vein very easily. Please don't park that lead there if you expect that area to be scarred. 100% the morbidity events will be much higher in those patients. Similarly, the whole premise of cardiac resynchronization therapy is to activate or depolarize the area where there is a latest depolarization of the ventricle. So if you find that you have implanted a lead away, very far remote from the area of latest activation, actually their mortality is much higher compared to a place, a person where the lead was implanted at the latest site of activation. So a simple tool, if you don't implant the lead in the latest area of activation, please pull out the lead. It may take another half an hour, it doesn't matter, it's well worth it. There are occasional instances, about 5% in our practice, that we end up sending a patient for an epicardial procedure, not because we can't implant the LV lead, but we think it won't electrically resynchronize that area. How do you recognize that? It's very simple. You look at the sensed bipolar electrogram, which indicates the local electrical activation from the LV lead, and ask the programmer, the Medtronic or whichever company guy is there, ask him to display a QRS, and you should be able to sense this local LV depolarization at the end of the QRS so that you can have optimal repolarization. Now, this is a very nice work which was recently published from France, which tells you about the heterogeneity that I was talking to you about non-ischemic cardiomyopathy. Because every one of you here would have seen an occasional patient with non-ischemic cardiomyopathy and an IVCD, not an LBBB, who has responded, and conversely who has not responded. Why does this happen? So if you look at patients with an IVCD, you have a uniform action of the septum. This is an AP view. There is an area of conduction block, and the impulse has to go around either through the anterior or the inferior wall and activate the lateral wall. This, what you see as this magenta purple color, indicates a very late activation of the ventricle. So, and the commonest reason in cardiomyopathy is because they have mid-wall fibrosis, and the fibrosed area acts as conduction block, and therefore the impulse activates this area very, very late. If you by chance have a vein either in this location or in this location, it is lateral wall. You have parked it anatomically in a lateral location, but you won't be able to depolarize this area of latest area of activation. So in other words, if you want to resynchronize a non-LBBB patient, you need to spend a little more time with your echocardiographer, with your MRI person, and then be willing to post him as the first case when you have a little more time on your hand to kind of choose the optimal vein to implant the lead. One way of overcoming this is technically, if it is all in the course of one vein, you can have a multi-site pacing among the LV. That is, this is called a multi-point pacing. This is used for patients who are considered to be non-responders. You can pace the LV itself from more than one site so that you can recruit a larger area of the left ventricular myocardium at the area of latest activation. And this results in a significant improvement in terms of responder rate. So, Chairman, ladies and gentlemen, in conclusion, I would like to conclude that all of you know that cardiac resynchronization therapy is an established therapy, over 10,000 patients randomized, and it's extremely useful in patients with poor left ventricular function and wide QRS on the ECG. However, do not recommend this for a person with systolic heart failure and narrow QRS. For non-LBBP patients, don't brush them aside saying that they are not going to be responders. Please spend time with your echocardiographer. Please get an MRI done to make sure there's no scar in the lateral wall. Then you may pick up some of those patients who are likely to respond even though they don't have a typical left bundle branch block. And please, left ventricular lead in a good target site is an important and an imperative factor to deliver the maximum amount of cardiac resynchronization therapy. That's an important technical factor that all of you can easily decide on the table by looking at the delay of the local ventricular electrical activation, which will tell you whether you're at the right spot or not. Thank you very much for the patient listening.
Thank you, sir, for your elegant talk on CRT indications and how to take care of non-responders in the choosing of the patient in the initial stage itself. I think imaging is coming up as an important tool to locate the scar and for the position of the lead and further redefining our LV lead position. Thank you, sir. Any questions to sir?
I think, Narasimhan, that conclusion 4 sentences, I think it is the take-home message for all the cardiologists who are non-electrophysiologists.
True.
Narasimhan, can I ask you something?
Sure, sir.
You selected your patients well and they are supposed to do well. How often in your practice you found they didn't do well and how did you deal with that situation?
Okay. We are now actually, Ashutosh is here, one of our colleagues is looking at this. We have close to about, if a patient is LBBB, we have close to 10% of them are non-responders. We have the actual data now. And one of the reasons why they don't respond is progression of scar. We can break down and tell you some of the things is worsening of mitral regurgitation, loss of LV capture because of scarring. We have found at least a small proportion of them, we have missed an underlying sarcoid in these patients, which are coming up later on. And fourth is patients have had comorbid illnesses which are causing worsening. Commonest is renal.
In other words, it's not a cure.
It's not. It's not.
Number two, I'll ask you another question. You have a narrow QRS but significant delay. How do you explain it?
So, if you have a narrow QRS and a significant delay on MRI, this is exactly the narrow CHF looked at. What it indicates is there is a small area of the myocardium which is contracting late, which is responsible for delay on tissue Doppler imaging. But the sum total of the ventricular depolarization is marked by your QRS duration. So the amount of muscle that we are likely to recruit by doing a cardiac resynchronization is very, very minimal, and therefore they don't do respond. A caveat is if a patient has the same setting but with a PR interval of 240 milliseconds. So when you have a PR interval of 240 milliseconds, when you shorten the AV delay, the diastolic mitral regurgitation disappears, the AV filling improves, diastolic. So despite narrow QRS, a subset of patients may improve, but very, very important, patient selection is important.
Yeah, that's very important to know. The ECG doesn't tell you everything sometimes.
Exactly, you're right. I'm glad you brought this out. When you have patients with atrial fibrillation, and if you think it's paroxysmal and occasional atrial fibrillation, once you put a CR, optimized medical therapy.
To complete his DM cardiology, pediatric and adult from the prestigious institute, Sri Chitra Institute of Medical Sciences, Trivandrum. Dr. Edwin also underwent short observership in advanced interventions from Boston Children's Hospital, Harvard Medical School. He has also been awarded Diplomat Award.
Good afternoon, everyone. Thank you for those kind words, and I thank the Telangana CSI and Dr. Kasturi for giving me this wonderful opportunity to speak on the current status of interventional cardiology in this part of the world. Can I have the markers, please? So basically, just touch upon the three areas like the past, the present, and the future, because to know where do we stand, we need to look at what is behind us and probably have to sneak at what is ahead of us. So what is pediatric cardiology? Like when even I started DM, there was pediatric cardiology was just in its initial era, like around early 2000. It's a specialty that deals with congenital heart disease at any age and probably in acquired heart defects in the pediatric age group. It's a very small specialty. Since I've written it in a small, it includes only a small area. Predominantly is congenital heart disease and structural. It's known as a separate entity in 1940s to 50s in the world, basically in the West. And then in India, it came to as a separate branch in 80s and 90s, thanks to Dr. Rajendra Tendon and Dr. Parvati Srivastava, who did create a lot of work to bring it into the decade. Probably you have the hybrids and the pulmonary wall placements and prenatal diagnosis and fetal interventions coming in. So just have a quick look at the past. As the morning Dr. Dayasagar has said, it's 1929, it's Frostman who started off all this when he put in his urinary catheter and walked to the cath lab, in the radiology lab, and then did his own angiogram. Then there's an X-ray to confirm, no, sorry, not an angio, did only get X-ray only at that point of time because there is no CNE available. So the X-ray showed that the catheter inside the heart. Again, it's a start of both of cardiology and pediatric cardiology. But when it comes to concepts of pediatric cardiology, how to go ahead to intervene, this is Helen Taussig from Johns Hopkins, she was a person who started the clinical cardiology and thought of intervening in pediatric cardiology, basically surgical. And coming to the father of pediatric cardiology interventions, obviously it is William Rashkind. It's in the 60s, he thought of this great idea about almost all the newborns and the infants were dying of the TGA transposition, as you all know. And he thought of this idea of making a bigger hole in the atrium to have a better mixing, so that, as you all know, you have there's a Rashkin's catheter, you make a hole in the atria, which causes a better mixing, and resulted in many of them surviving to a longer age group, so that they could be operated at a later stage. So this was initially lauded by few, but then he got into trouble because of this, because it was looking at very grotesque when you look at it, it is around 50 years back, somebody think of tearing away the atrial septum. But this is the start of pediatric cardiology interventions. So looking at purely on interventional side, it is again in 1960s, the Rashkin's balloon came in, and then it took another decade or so, the first time to develop an atrial septal device by King and Mills, which we never got an FDA approval. They did in 3 cases. They succeeded in 2 in the first case report is published. But it took another 2 or more than 1 to 2 decades to develop a proper ASD device which can be routinely used. Then came in 80s the use of balloon catheters for dilatation of aortic wall or pulmonary wall. This was pulmonary wall came better. Then came in 90s or late 90s when obviously the ASD device which came to be routinely used came in the device by Kurt Amplatz. Until then, pediatric cardiology was never taken seriously. Then came the 2000, the fetal programs, the hybrids, percutaneous pulmonary wall. Majority of the interventions usually follow the adult interventions because we usually don't have a standing on our own till a few years back. Just to comment, my previous speaker spoke about like Krieger did the pulmonary wall, like aortic wall, but probably the pediatric cardiologist Bonhoeffer did a year or 2 earlier, I think in 2000 if I am right, did the first pulmonary wall, then Krieger went on to do the aortic wall 2 years later if I remember right. So the first time probably an adult pediatric cardiologist went ahead of the adult cardiologist. In all other phases it's usually lags behind. What are the current interventions being done for the current status for the juniors? Its majority is again is ASD and PDA or a VSD. So almost 90%, probably for 95% of interventions probably done at present, it include in the first either ASD, VSD or a PDA and a few coarctations. Less common interventions probably can be easily done. One of the first to be done in India is a balloon pulmonary valvotomy by Dr. Savitri Srivastava in long back in early 80s. But after that, other than that, it was a few numbers. That's balloon aortic valvotomy or balloon pulmonary valvotomy and aortic. Then you have few balloon atrial septostomies and pulmonary artery stentings. Then come the newer interventions like a PDA stentings, hybrid interventions, pulmonary valve comes a very narrow, small percentage, less than 1% probably. So when it comes to then the ASD, we'll just go to the ASD. This is Kurt Amplatz, the person who developed the atrial septal device. It was almost a year and more than 20 years where the first ASD device was implanted by King and Mills. But then this took this radiologist working with his son, he was also a physician, in his lab to devise this Amplatz device, which is now the standard for almost all devices. Atrial septal defect is one of the easiest one to be closed in the surgically, and then that's only one which can be done easily as of now in the cath lab. Almost 80% can be dealt with in the cath lab, probably 90%. It depends upon the anatomy of the defect, the patient characteristics, quality of the imaging, and the operator skill. This involves any intervention for that matter, especially in pediatric cardiology, because the anatomy of the defect is most important. It varies a lot. It has a great variation, unlike the coronary stuff. And then the patient characteristics varies. It could be a newborn to a 80-year-old guy. So it varies quite significantly. Your hardware all varies according to the size of the patient. And quality of the imaging, again, very exceptional is required. Unlike you don't base on angiogram, it's based on echocardiogram. So if it's a younger, smaller kid, you can do by a regular echocardiogram. But it's an adult patient, you may have to get a transesophageal echo or an ICE to get a better image. And then there's an operator skill, obviously happens. There's a regular TE which of a transesophageal echocardiogram of an ASD which can be easily dealt with in the cath lab. You have a deficient aortic rim, other than that, it's a very clean stuff. As a three-dimensional echocardiogram, which not regularly add much to the interventionalist other than to demonstrate it better, because the discretion at which that level of clarity which given by a 2D is not yet received in the 3D, but in future it may be the future. These are the devices which first came into the work, the King and the Mills device, which first one, which are the few stainless steel rods wrapped on a nitinol, not on a PTFE, and then on either sides. But none of these devices never got an FDA approval. There's a lock clamshell, the Jim lock device, this one, but none of them were routinely used now. This is a routinely used device. As you all know, this is made of nitinol. It is around 45% nickel and 55% titanium, which has a memory, which is made of wires, which made into a central waist and either sides retention skirts available. And it ranges from 4 to 40, but many other companies makes bigger ones. These are the FDA approved devices which is available as of now. Again, it's majority of them are copying of the standard Amplatz device. The Occlutech device is available. You have Sera, like the LifeTech device, and the NIT occluder is also available. But again, majority of these are Amplatz which is used all over the world. This is a timeline of the same thing, which is the first one in 1975 came in, then the first device, but it took to the late 90s to develop a reasonably usefully device which can be used easily. So these are a few 3D echo pictograms of an intracardiac procedure of well being done. This is one of the few papers which we have published long back in 2003, which on the large devices, and 2009 on deficient rims. Now we have with the live LA appendage devices, those patients who are elderly with the atrial fibrillation chronic, we can go ahead and close the LA appendage to prevent clotting, and then probably can finish off the device also, so that there is more complete cure. We can't say cure, but at least a more easier treatment. We can avoid the anticoagulation after 6 months. The newer developments in the ASD device is again obviously the most wanted one is the bioabsorbable devices, which are being tested. Animal experiments are over. Maybe in another few years' time it will be available commercially, which are basically magnesium-based devices, which still not available commercially, so we're not going into in details of that. But what are situations when we are not going to use a device? Probably this slide, I think I made long back another. This is a primum ASD, sinus nose ASD, a large secondum ASD with absent margins, and large secondum ASDs in those small kids. Except for the primum ASD, almost all the other things can be tackled, provided you are very sub-selective and very careful in selecting the patients. Because I have done a 46 mm device around 8-10 years back, but you have to be very careful of a 41 mm defect in a sick adult patient. You have done a lot of small patients. The youngest one done as 4-month-old, which is coming with refractory heart failure. So it can be, all the rules can be closed. Even a sinus venous ASD can be tackled probably. We'll just give an example here when we are here. This is a balloon occlusion of this SVC to make sure the pulmonary vein is flowing well. Sorry. SVC to make sure that there is a pulmonary vein is not obstructed, so that occlusion of the SVC doesn't give trouble. Okay, fine. So this is markers are not working. Okay, fine. Okay. LED doesn't work. Why does it work? Okay, fine. So this is a balloon occlusion of the SVC, and make sure the right upper pulmonary vein is not occluded. And then this is once it innovatively we can do almost all ASDs now at present, but this is, we may planning to have a de novo stent made similarly for a custom made for this. It's being developed. So the concerns are now ASDs have been routinely done. A few things you have to be careful when you blindly do close or